You facing the light?
Hey, my name is Grace Mason. I am an oncology nurse coordinator at Kaiser Permanente. Thank you to all who are watching it online via YouTube, and thank you especially to those of you that came today to view my presentation. I'm sorry we didn't have a larger group, but due to spring break, I could not bribe any more people to come. So thank you so much for coming. This presentation is about patient safety, and I'm doing it for my senior project class at Columbus State University. So if you have any questions throughout this presentation, don't hesitate to just give me a sign or just speak out your question. So we'll get started. This is National Patient Safety Goal Highlight. I'm sure we all know about the Joint Commission. Most of us probably run and hide when we hear them announce Welcome Joint Commission over the loudspeaker, and we try to find something very busy to do. But what I've found out over many classes that I've taken at Columbus State is that the Joint Commission actually is primarily focused on patient safety. And I'll try not to read directly from the slides because that is very annoying, but I did find some very interesting information about the Joint Commission as well as National Patient Safety Goals on their website. There are some things that I wanted to just highlight. The Joint Commission was established in 1950, and it was called the Joint Commission on Accreditation of Hospitals. In 1953, they published their very first standards for hospitals, and it wasn't until 2002 that they actually created the National Patient Safety Goals. And those National Patient Safety Goals were then implemented in 2003. The Joint Commission has went through many name changes, and currently they are just being called the Joint Commission.
Do we use the Joint Commission?
That's a good question. So here at Kaiser in Georgia, we do not use the Joint Commission for accreditation, but it is frequently used in research articles as well as just across the board as the golden standard on accreditation. The main point of this particular slide is to state that the Joint Commission makes changes to the National Patient Safety Goals. Sometimes the goals are added. Sometimes there are goals that are added to the set of standards and therefore removed from the National Patient Safety Goals. Occasionally they add additional requirements, and sometimes they even remove National Patient Safety Goals, but usually that's just to do further research. So this is the list of the 2018 National Patient Safety Goals, and they can change based on the type of facility. So if it's like, let's say, a mental health facility, they may not use every single one of these goals, and so on and so forth. But these are the current goals. Number 1, improve the accuracy of patient identification. Number 2, improve the effectiveness of communication among caregivers. Number 3, improve the safety of using medications. Number 6, reduce the harm associated with clinical alarm systems. Number 7, reduce the risk of healthcare associated infections. Number 9, reduce the risk of patient harm due to falls. Number 14, prevent healthcare associated pressure ulcers. And then number 15 is organization is to identify safety risk inherent in its patients' populations. Question?
Yeah. How come they're not listed in consecutive order?
Well, that's a good question. So as you can see, it goes 1, 2, 3, and then 6. So there are some that are not there. So basically, when the Joint Commission creates these National Patient Safety Goals, their number stays the same. They may add on to it. So they may have an 01, 01, 01. And 01, 02, 01. So they may add on to it, and they may actually remove them. So let's say the National Patient Safety Goal 4 is likely currently a standard or a universal protocol. So those numbers always stay the same. Does that make sense?
Yeah.
The goal that I chose to specifically highlight is goal number 2, and that is improving effectiveness of communication among caregivers. As stated on the slide, there are specific elements included, such as develop written procedures for appropriately managing the critical results, implementing said procedures, evaluate the timeliness of reporting the critical results. I wanted to highlight goal number 2 because although for the National Patient Safety Goals currently it's specifically regarding results and critical results, but I think that we can learn a lot in healthcare in the way of communicating if we just focus on one aspect of it, and then go across the board and use that technique for communication across the board. So, communicating results. When a result is called to the nurse, it is our duty to document and report it correctly. And in the way that we document it, the most important thing would be to make sure that we read back and verify, or read back and verify. So there's a lot of misunderstandings. People have accents, people have a million things going on. So when somebody calls you a result, you want to make sure that you are reading it back to them to make sure that you understood exactly what they're saying. And then you want to make sure that you are prepared when you call the provider with the appropriate information. And we use SBAR, Situation Background Assessment and Recommendation. There are many templates online. There are worksheets that you can use, or as you become more familiar with it, it just becomes second nature. And that's an important way to communicate all the relevant information to the provider, to another nurse, really to anybody in healthcare. This is just an example of one of the SBAR formats that I found online, but again, there's tons of them. You'll see that it actually gives specific information that you can write down so that you are actually getting the pertinent information. So you receive a call from the lab reporting that Jane Smith has a critical hemoglobin of 6.2. So you may want to run up and down the hallway screaming for help because you don't know what to do with the hemoglobin of 6.2. Or you may immediately hang up from the lab and call the provider and tell them that the hemoglobin is 6.2. Or you may write those results down on a sticky note and immediately lose that sticky note and forget all about that hemoglobin of a 6.2. And all of those things are really wrong. So we need to make sure that as nurses we're prepared and that we have all the relevant information. So the appropriate thing would be to proceed to the patient's room to complete an assessment, and that assessment should include vital signs, pain, noting skin color, alertness, quality of breathing, anything that you would note in a person that was actually symptomatic for their anemia. You can ask the patient questions about how they feel and inquire about active bleeding if you otherwise don't know that they have bleeding, and about their history of anemia. And while you're there in the patient's room, there's generally some type of computer or laptop or something where you can access the patient's medical history. So while you're there in the patient's room, you can pull that information up and write that down on an SBAR template and prepare to call the doctor. So that information that you'd want to make sure that you have is the patient's name and date of birth and their health record number and their location, as well as the most recent results prior to the critical results. And that's very important because if you just call them with a hemoglobin of 6.2 and you're not looking at the previous results and you think they should do something, Who knows, their hemoglobin could have been a 5.2 before, and whatever they're doing is actually working. Or their hemoglobin could have been a 10, and you know that we need to look for some type of active bleeding. So it's important to look at prior results of vital signs, prior results of labs, whatever it is that you're contacting the doctor about. And you also want to make a note of the patient's diagnosis, their current status, any comorbidities, allergies, and any other pertinent information. So you're basically getting prepared. And now you're prepared to contact the provider. And you're still there in the patient's room, and you still have the computer chart open, so if they ask you questions, you can immediately respond back to them. So you're ready to call the provider, and you feel very empowered, and you would basically go through situation, background assessment, and recommendation. And you wouldn't actually say those terms, but basically, for example, hello, Dr. Doe, this is Grace calling from 2 North. I'm calling about your patient Jane Smith, date of birth 5/6/76, who is in room 206. I received a call from the lab reporting a hemoglobin of 6.2. Ms. Smith was admitted on April 1st with exacerbation of COPD. She also has a history of fibroids with heavy menstrual cycles and diabetes type 2 and has an allergy to latex and eggs. I've assessed the patient and I'm here with her now, and her vital signs are stable. Her quality of breathing and respirations are normal on room air, and she's alert and oriented. Patient's last hemoglobin from 2 days ago was 7.8, so we know there's been a drop. Patient denies any active bleeding but admits to finishing her menstrual cycle on April 3rd. Patient also admits to a history of chronic anemia with previous iron infusions and a few blood transfusions in the past. Now it's time to recommend. So this is part of the nursing process. You have to know what is needed for your patients. Would you like to order a type and cross for a blood transfusion or an iron infusion? Would you like to repeat the labs and include iron studies? By providing all pertinent information to the provider using SBAR and then using read back and verify method, you are ensuring that you understand the appropriate information. So now we'll talk about read back and verify. You're going to listen closely to the instructions from the provider, and I'll let somebody else read this off. Go ahead.
Please type and cross and hold 1 unit PRBC. Order stat labs of
Hemoglobin and hematocrit.
as well as iron, TIBC, and ferritin. Once the new results are back, I will review and order the appropriate treatment. Please increase vital signs to every hour until I am able to come assess the patient.
So now you've heard what the doctor has to say. And you may not understand them. You may not understand that accent. He may have been doing 2 other things. You're probably doing 20 other things. We need to make sure that we understand each other. And this is where your read back and verify comes into play. So to review, you'd like me to order a type and cross and hold 1 unit of packed red blood cells. You need a stat hemoglobin and hematocrit as well as iron studies to include iron, total iron binding capacity, and ferritin. You'd also like us to perform vital signs every hour until you come assess the patient. Is this correct?
Yes.
Any questions? No? Okay. So, of course, we did some research and found some great articles. What I found during my research is that I continuously came upon information about SBAR in communication related to patient safety and just a whole array of information that says that SBAR is an effective means of communication. This particular article is called SBAR Communication and Patient Safety, an Integrated Literature Review, and it was especially helpful. I really liked this particular quote. Use of SBAR improves efficiency, efficacy, accuracy, and handoff report. There are obviously issues with communication. I think we've talked about some of them throughout the slides, but lack of standardized process, complexity of healthcare, omissions of information, culture of the organization or the different hierarchies, and then communication in healthcare has been established as a leading root cause for sentinel events. We cannot improve our communication if we don't understand what the issues are. This research article that I found here was a multidisciplinary collaboration called Improving Nurse-Physician Teamwork, which actually highlights collaboration between the nurse and physician and the strength of communication on healthcare. We cannot be afraid or intimidated to discuss our concerns, to report what we find to the providers. And one way that we can reduce how we feel that intimidation is by being prepared. So nurses, we're the frontline caretakers that are usually the first to discover a change in a patient. And then again, another quote, in an effort to improve communication, the Joint Commission added a national patient safety goal in 2012 to improve staff communications. So communication is extremely important to a patient's overall well-being. This third article was probably the best article, and it actually came from University of Tehran, or Tehran University of Medical Sciences in Iran. So I know it's not from the United States, but what I really learned about this is that communication and the lack of communication is a global issue. We're not the only ones here in the United States that are dealing with it, and I think we can learn a lot, especially from other countries. So quality and safe patient care is a direct outcome of clear and effective communication. And then I especially like this, professional communication in clinical settings is healthcare professionals' relationship with each other, as well as their exchange of knowledge and skills for making wise clinical decisions about patient care. So again, this was probably my favorite article, so I urge you to read it. The full length of it is available, and it's very good information. My final takeaways for this presentation are nurses are the primary facilitators, coordinators, and mediators of patient care. Standardized communication techniques can improve a nurse's confidence. Preparing prior to providing important information can increase the receiver's trust in the nurse and the information provided. Improved communication directly affects a patient's outcome in healthcare. And the biggest communication problem is we do not listen to understand, we listen to reply. This presentation will be available via YouTube, but I don't have that link yet. You have a question?
I do have a question. Do you think one day we at Kaiser will take on Joint Commission, or do you think our current program is well suited for our company?
I don't want to get in trouble for saying anything, but I believe that they're probably going to continue with the company that they use due to the cost. There's been a lot of companies that have popped up over the years. DNV, they've actually been around for centuries, but now are getting into healthcare. So although the Joint Commission is a standardized golden seal of patient safety and accreditation throughout healthcare, I'm not sure that Kaiser would use Joint Commission. Thank you. Do you have another question?
I have another question. What sources did you use to find your research article?
I used, of course, Galileo, which is a resource that's used through my school. And then through there, I use SynHall, I think is what it's called, and then PubMed. And SynHall is where I came up with 2 of the articles, and PubMed was that third one, the one from Iran. Any other questions? if you do have questions that you think of later, by all means, just contact me. I can make the presentation available to you via PowerPoint, and again, it will be on YouTube eventually. And then I want to thank you all so much for participating and reviewing my patient safety presentation. My references.